Hi everyone, dear colleagues and partners. I'm happy to present for you the International Digital Health and AI Research Collaborative work based on a joint research project that we are co-leading with Dr. Bano from CMC Valor. But beyond that, I'd like to talk a little bit further about how we are aiming to scale up our research in healthcare by leveraging the learning health system and making it one core element of our strategy in the scaling up. The scaling up is very critical in terms of improving the patient outcomes and also to driving the innovation in the field. And I think is an essential element is how to expand the scope of research when it comes to the learning health system to be able to identify new treatments, new diagnosis approaches, optimizing the way to intervene, and develop new technology to manage all of that. Scaling up research will also allow for larger sample sizing, which can help identifying patterns and trends that may not be apparent in smaller studies. And additionally, this can help to address health disparities by ensuring that underrepresented populations are included in clinical trials and other research studies. But today will be an example of how we have done that and what does it mean to scale up research from our point of view. First of all, we need to state that the learning health system and the cycle of evidence-based cycle of research in learning health system is very similar to the AI research. That gives us a very suitable approach to integrate the AI inside of the evidence-based research, since both of them are based on more or less the same elements. In fact, a learning health system is that is done to enable healthcare providers to collect and analyze data on more data on patients. They can identify these best practices and improve the quality of care by continuously learning and adapting from the practices. A learning health system can help to bring faster, quicker, and best evidence inside of the practice based on the data that are generated on a daily basis of the practice. This is a continuous cycle where the learning never stops and the optimization is a continuous process rather than one shot. This is more or less the same case of AI research, and then if I should give an example, I'll talk about the ChatGPT 3 and 4. So as soon as they have reached a critical mass in this ChatGPT 3 2 months ago, it was released, people start using it, and that brings more data inside of the training data sets and better accuracy since there's more feedback coming from end users. And that enables a very quick scaling up from GPT-3 to GPT-4, which takes less than 2 months in the process of the implementation. And then I think that this kind of approaches is making the progress much faster, especially in the AI. And if we apply these kind of approaches in the AI for healthcare, we may be able to quickly generate better evidence, but also to quickly optimize our practices and generate better data for even better evidence later on. But let me give you the concrete example first of what we have done and how we have scaled up our research project. First of all, the research context, as stated before, is based on the practice, daily practice. For my case, as I was in the palliative care unit, mostly with patients with late neurodegenerative disease, the research question comes quickly from the context of our patients. How do we recognize that the patient is in pain and when they have advanced dementia and no communication ability? If you look at numbers are very dramatic. Patients in the same conditions, with same comorbidities, at the same age, or the same cohorts, those with neurodegenerative disease are receiving half of the analgesic that other patients with communication abilities. There is what we've been talking about since maybe 10 years now, which is this chemical camisole that is transforming the patient from human being to zombie being, where they have no further any kind of interactions, and that quickly reduce their life expectancy, but also dramatically worsen their end-of-life quality. And then this psychoactive or antipsychotics drugs have been used to control residents rather than to reduce their pain. So often we have seen that patients in pain, rather than getting analgesic, they are taking antipsychotics. And then that's for very simple reasons. For example, in Switzerland, we often use the Doloplas medical scale to measure the pain level of our patients. This is very time consuming. It requires a lot of skills, but also require time of observations of our patients. Moreover, these kind of medical scales can only be used once every 24 hours. So we can miss the time of the pain or the time when our patients are in pain, under shower, eating, sleeping, a worse position on their bed. We can miss this very easily. So the question was, how can we bring the digital and AI innovation inside of the healthcare system in the palliative care unit to reduce the use of the chemical camisole? First of all, we need data. We need to understand where are the data, how to collect it, and how we can transform this Doloplas medical scale into something fully digitalized, and that can come without any human interventions, with quick results or decision-making process or alerts showing and stating that some of our patients are in pain. So first of all, we've designed this clinical trial about how can we define the digital biomarkers of pain. And then we have been looking into the market. What do we have as medical grade wearables that can be used in safe manner with our patients? And then we end up with several immediate sensors and derivative data later on, like the heart rate variation, the blood variation pressure, the electrodermal activity, the movement, and sleep patterns. These are today very commonly existing sensors, and it's very easy to find any wearables that can provide this kind of data. Moreover, since the pain is very subjective marker, we've been looking into different other data, either coming from the individual histories, pain sensitivity, quality of life, social determinant of health, but also the environment within the palliative care unit and the impact of the environment on the patient well-being. Once it's done, you start the collection. And this is an example of 1 day, 5 sensors collection. So we have the temperature, we have the movement, we have the electrodermal, we have the interbeat intervals, and the acceleration. And then we can see moments where patients are sleeping, moments that patients are in agitation, and moment where patient can be clearly in pain or can be in very bizarre moments in their life, in their daily activity. With the data collections, we start some analog measurements. So we have got 2 cohorts. The first cohort is patients with no communication abilities. So we are recording the entire data, but there is no further analog measurements. The second cohort is patients with communication abilities. And then we have used the data collected from these patients to label the data that we are collecting, specifically to label the pain moments in their daily activities. So when we ran our machine learning later, we ran specifically for these specific moments where we are sure that patients are in pain. So we collected 2 million records for each patient by day during 2 weeks of admission in the clinical trials, and we've collected that for 25 patients, 15 with communication abilities, 10 with no communication abilities. Then we have done the curation process, the analog as digital data, which is this labeling process, and we end up, due to the amount of data, to create a semi-automated data cleaning process to accelerate the process of integration of this data inside of the research we are conducting. So we end up finally with building these machine learning models that give us the impression, at least, of understanding pain or detecting pain from census data. If you look at the tree signals, whenever the signals is higher than a specific threshold, which is in our case 0, which is no pain at all, we can more or less say the patient may be in pain and we need to intervene in that case and to make some observation regarding our patient. At the end, with this amount of data, since we have much bigger data labeled in no pain than data labeled in pain, we have a better precision of prediction of the no pain, which makes sense. We can easily predict that patient is in no pain, and the precision of detection of pain is performing less, so it's 86% rather than 100% of the no pain. That means that this is not, this requires a human intervention. This requires observation of the patient to be sure if the patient is in pain or not. But what we can now state fully with full confidence is if the patient is in no pain and if it requires human interventions or not. So the optimization of the process now is based on priority based in our patients. So patients with no pains will be cured at the end of the interventions, while patients where we suspect that they have pain are prioritized. That's how we have optimized the palliative care pain assessment process inside of the units. Now that we have done this, we need to bring more evidence and we need to show how the model is performing better in order to be able to integrate it later inside of the practice. And this brings us back to the healthcare learning health system, where we continuously bring back the findings and that are evidence-based inside of the way we deliver the healthcare process. For that purpose, we have moved from the pain to the agitation, which is labeled either under the BPSD, which is Behavioral and Psychological Syndrome of Dementia, or directly linked to the pain. So if we can evaluate the agitation and reduce the agitation among our patients, it's something that is linked to the previous research about pain, and it can be something that can reduce the burden inside of the palliative care unit and among our healthcare workers. So we've picked a very specific use case of agitation, which is the sundown syndrome, since most of the interventions that needed for the reduction of sundown syndromes among our patients are linked to non-invasive interventions, and they are very easy to implement in palliative care. So the sundown syndrome is a syndrome that appears among patients in the early morning or late afternoon or early evening, and patient shows a lot of agitation there, and the interventions are often very simple. We need to turn the light on, we need to heat on the room, we need to put some music, or to take them out of their room, to put them in a social environment, and that drastically reduces the agitation among our patients. This agitation can be linked to the pain. So what we need to know if are they in pain, so we give them analgesic, or is this linked to the sundown syndrome? And then in that case, we will deploy digital interventions. And during the first clinical setup, to distinguish between patients that are in pain and agitated and analgesic intervention, and patients that are not in pain but they are suffering from sundown syndrome and they need different interventions. What I have seen is that among their admitted patients with history of records in health records that present a very high score of Pittsburgh agitation scale, to date, we have reduced the PANSS to 7.6 from 12, and by the usage of the Zarit burden medical scale, we can see that we have a significant reduction of care burden. Our healthcare workforce can get a better decision making because they can see if the agitation is coming from the sundown symptom or from a painful situation among our patients. And based on that, they are making better decision because they don't need to spend time doing the Talo Plus anymore or looking for the Talo Plus. So we got the validation. Now, how can we scale up this validation to the next level? The idea behind it is that we have very few elements that can define the quality of life in our patients, which are depression, mobility, self-care, usual activities, and discomfort. So these 5 elements, if we are able to extract the discomfort or pain, if we are able to extract mobility, since it's already included inside our sensors, if we are able to extract usual activities, since this is incoming within patterns of activities, but also geolocalization and a lot of other information that are being collected about usual activity, we still struggle with depression, how to detect the amount of anxiety our patients are suffering from, and the self-care. For that purpose, we start looking at the depression to see if there is any way to change the way we evaluate the level of depression or anxiety from a digital paper structure to a digital biomarker structure. So from analog paper to digital biomarker. And then if you look at the existing medical scales, there are a couple of questions there that serve to determine if our patients are under stress, is it also under pressure and depression or not. So we have defined a couple of biomarkers that we suppose that will help us filling in these questions without asking questions directly to our patients. First of all, data sources. We've been looking into the cohort of patients with communication abilities for the moment, and we have equipped them with a smartphone. The smartphone, as you may see, there is a couple of data that are coming directly from the sensors that are embedded. Then there is a couple of data that is coming off the interaction, the human interactions with the screen. And finally, there is a couple of information that can be extracted from the log file of the smartphone about the concrete activities that are being conducted there. So if we look at the first set of sensors, most of them are location-centric markers that could define different other elements that we require to define the digital biomarkers of depression, like the location, the GPS, is it a GPS or not? Is it a public or private Wi-Fi? That we can understand what is he doing, what kind of activity our patient is doing, the luminosity level that could help if he is outside or inside, the temperature, the day, the time, the sound surrounding him. It's already being done for a couple of advertisements, so we think that we can do it in non-intrusive manner for the healthcare monitoring too. So these are very basic centric markers. Then we have the user-centric markers, like the posture based on the G sensor inside of the mobile phone, the situation, and we can derive from that the sleep frame, activity, the category of activity, and the number of social interactions based on his mobile phone usage. But that must be linked and calibrated with his previous activity. Finally, we have a couple of these questions. So, for example, we pick the first one, which is persist at a task or conversation for several minutes without stopping or drifting off. This is one question that we have in medical scales that we need to translate to be answer it by the use of digital biomarkers. And then these answers are coming from what we call the behavioral actionable intelligence, where if you look at the different case scenario that we can implement, we can see that, for example, ending typing message without launching other application. That means you persist at the task. So that if you can do that, we are answering yes to the first question. We can also look at the number of simultaneous launched applications in a very small time frame, and the number of achieved and realized actions like search and call, read and answer, display and read. And all these data can be collected directly from the mobile phone. If you pick any other question that is coming from the questionnaire, like performance is best early in the day or after rest, we can see it in the interactions with the mobile phone, number of corrections in a message, depending on the time, the average time of message writing, and number of interactions like clicking and sliding. Once we got all of that, we can translate the depression question into digital biomarkers that can be collected. And then we are more or less scaling up our research from early pain, agitation, now depression, and quality of life. How can we take forward this research project to a further scaling up? We've clearly reached some limits when it comes to the hardware or medical wearables that are being used, and that's the reason we are currently looking into open hardware wearable that can integrate directly dolometer. And then this dolometer, the tool that we use to edge AI to measure the pain, would be very beneficial for informal healthcare giver. So we would like to give it a try for discharged patient to see if we are reducing also the burden on the informal healthcare giver, and how effective is that in unsupervised environments. And then we would like to start the clinical validation of mental health assessment scales, which I've been talking about, which currently is being implemented. And finally, from these digital biomarkers, we can soon start building different frameworks like patient-reported outcome monitoring, where rather than giving the patient a paper-based questionnaire, we will simply collect the data directly from the patient and transform that into either experience or outcome understanding of the patients. And that will be helpful to development of new standards for preventive outcome monitoring. If we implement preventive actions with our patients, where patients are not suffering from any condition, but we would like to reduce the risk, that will be much more useful, because at this time, the preventive outcome monitoring got no specific medical scales to be monitored. But we think that digital biomarkers could be the best way to implement better, more performing preventive outcomes monitoring. Thank you all for listening to me, and hope to see you all soon.